All right, everybody, it's time to thrive in 5. And we are going to be talking about what happens when you get a phone call in the middle of the night when you're on call as the anesthesia provider, and you need to provide sedation for a patient who has had a heart transplant, and you're not really in a cardiac center. Okay, here's what you need to know. So first of all, remember this new transplanted heart is denervated, right? It's basically been deprived of its nerve supply. It has no parasympathetic, no sympathetic or sensory innervation to it, all right? There's no intact sympathetic nerves, so there's no normal uptake and metabolism of catecholamines. However, they do have circulating catecholamines, and that's how they can increase their stroke volume with the circulating ones, okay? They're also, this new heart is going to be very preload dependent and very sensitive to changes in preload, okay? Cardiac output depends on the venous return, all right? They are also unable to respond to hypovolemia, hypotension with an increased heart rate, all right? Because they don't have that innervation anymore. This heart is denervated, all right? Your resting heart rate now is going to be about 90 to 110 because there's no parasympathetic innervation to that heart. You have less vagal tone, and it's common for your EKG to see a first-degree block. Their sinus node has an increased refractory period. You may see some ectopic beats, and you may even see 2 P waves from 2 SA node input, okay? Your SVR is going to be increased in here. They may have a high to normal cardiac output. You also may see mild to moderate MR and TR, mitral and tricuspid regurg, and also these patients might have a pacemaker. Great. So hopefully you have a little bit of time and it's nothing emergent. All right. But preoperatively, what you really should do is get in touch with their transplant team. All right. I would talk to their transplant team. Whoever is with them, they should, if it's a minor, if it's an adult, they should have the numbers to that and let them know, is it okay to do this procedure here? Have a conversation with the transplant team. Questions to ask them as well. When was the transplant? When's the last time they've taken their immunosuppressants? We're going to talk about that in a second here. And then you do everything that you normally do. How do their other organs function? That's the question, right? How are the other organs functioning? So make sure you get a set of labs. Check out the most recent echo, get an EKG, look at that, find maybe an old one to compare it to. And their meds, how are they functioning? What does life look like for them? All right. And if they have any type of arrhythmia or change in baseline, heck no, do not touch, do not pass go. Okay. And then also looking at other comorbidities. A lot of these patients might have diabetes, seizure disorders, hypertension. They might have gallstones, pancreatitis, peptic ulcer disease. You might want to be thinking about some protonics or getting some Pepsodin, adrenal insufficiency, renal dysfunction, bone marrow suppression. Okay. So be sure that you are doing, your normal full preoperative assessment. And the question really is, how well do the other organs function? What is their baseline? Where are they at? And what are they looking like today? Another thing I want you guys to think about preoperatively is infection, right? They are not going to have the normal signs of infection due to being on these immunosuppressants, okay? So really clean. I mean, really be, I don't say the word clean, really be very diligent about your aseptic technique, your sterile technique and clean, because obviously being on immunosuppressants, they are at risk for infection and they're not going to show signs of infection per usual. You also want to make sure that they're not having any signs of symptoms of rejection, because rejection of that transplanted heart can happen at any time. So some of the signs could be recent weight gain, fever, shortness of breath, peripheral edema, rashes, abdominal pain, change in bowel or bladder habits, and they might even have a high DNP. So that's why it's really important to look at what their baseline, EKG labs and things are. Where are they at baseline? Do they have any of these symptoms when they come to you? Because if that's the case, then I would not proceed. Okay, let's talk about immunosuppressants really quick, and then we'll get into all the Intra-Op stuff. Some of this covers this as well. So you have these new school ones, is the mycophenolate and the azathioprine. So those are the new school ones. They don't have quite the implications that these two that we're going to talk about, but you might still see patients on these two. But a lot of times they're on these new school ones, which, like I said, have less of this. And also another thing is they may or may not be on steroids, okay? So ask them if they're on steroids, when's the last time they were on steroids. You only need to stress dose them if their steroids have been maybe recently taken away. So within like the last few weeks, the last month or so, I would consider stress dosing them, but be sure to ask about if they're on steroids or not. All right. So the other one, cyclosporine and tacrolimus. All right. So the things with this is you want to get blood levels, like need to get blood levels to see where they're at. That's why it's important to ask them their last dose. And you also want to be careful with IV fluids because you don't want to dilute out these blood levels. All right. So you might need to check them, before, you might need to check them after to kind of see where the patient's at. Okay. Because we want to keep their blood levels where they need to be. These are CYP450 metabolizers. So keep that in mind. And these drugs are known to increase the blood levels of Versed. So and just in general, obviously with the heart transplant patient, dose low, go slow, right? So be careful with the Versed. It also may increase the analgesic effect of fentanyl. Also may increase the action of neuromuscular blockers. So I was reading in the literature and they do say cis-etricurium is preferred for them. However, if you need to use ROC or VEC, just a little bit and see how they do, okay? These drugs may also decrease renal blood flow and their GFR, check their labs, see where they're at, see where their baselines are, all that good stuff. And then they also decrease the seizure threshold. So you want to be cognizant of that. So you want to be very careful with hyperventilation and blowing off a lot of CO2 because you don't want to further exacerbate the seizure threshold in these patients. With cyclosporine, it also may cause gingival hyperplasia. So they could be, you be careful with any type of bleeding or anything when you're manipulating that airway. All right, so how do I choose the best anesthetic for these patients? I mean, obviously less is always going to be more. If you can get away with any type of sedation, we'll talk drugs in a second. I would probably choose the sedation if possible. If not, GA versus regional. And regional, I'm talking like a spinal or something like that. You have to be very, very careful because remember, they're preload dependent. So they would be a huge hypotension risk with the spinal due to pre-existing, autonomic neuropathy, cardiac denervation. You don't want to have them hypovolemic and do a spinal. So you may want to just stick with GA where you have a little bit more control. Even still then with the vasodilation that the gases you want to maintain that preload. If you're questioning any type of major surgery, or if you're just nervous, put an A-line in, put a Foley in so you can watch their eyes and nose very closely. You can obviously watch their heart very closely with the A-line. So those things to think about, maybe an epidural because you have a little bit more control if that would work. Nerve blocks would seem to be okay. All right, so Intra-Op. So remember, they don't have sympathetic innervation, right? So they are not going to have tachycardia from pain and stress, and even from hypovolemia and even from hypotension, right? Because everything is depending on the circulating catecholamines. There's no innervation into that heart. So even with DL, direct laryngoscopy, there's not going to be a sympathetic response to that because they've lost their baroreceptor reflexes as well, all right? They're also their heart rate. Like if they're not deep enough, if they're having a lot of pain, you're not going to see that normal tachycardia, right? It's going to be, and they're even going to have blunted responses to hypoxia, high CO2. Okay. So if you have it, I would definitely throw a biz on them and just, watch them very closely and really try to, think about, okay, this is a stimulating part of the procedure. They're not going to show me they're in pain. How can I kind of attenuate this by increasing my anesthetic depth now, giving them a little bit of analgesia, stuff like that. And if you Valsalva them, it's also not going to have an effect on heart rate. Okay. You're not going to get that when you Valsalva, you're not going to see that vagal response. Okay. They are at risk for blood clots. Usually they are on blood thinners. Another thing to think about for Intra-Op and looking at that pre-op aspiration risk. They may have delayed gastric emptying as well. So I said before, they might have peptic ulcer disease and stuff like that. So getting in maybe some Pepcid, potentially thinking about an RSI depending on the case, and really just doing a nice slow cardiac induction. Okay. Being very deliberate, very careful, having your, pressors and stuff available as needed, and getting them at least a bolus of fluids in so you have a little bit of wiggle room there, getting that, saline or LR bolus in so you have some preload for them. Okay. And then you really want to avoid any acute huge drops in vasodilation and preload. So like once again, if you're thinking there's going to be some big volume shifts, it's bowel surgery or something like that, definitely need to get that A line in, get that Foley in so you can pay really close attention to those I's and O's. All right, last but not least, drugs, my favorite thing to talk about. All right, so neostigmine may cause basically cardiac arrest. That's what I've read. So I would say get Sugammadex. I know there's been a little bit of mix in the literature, but I did read some things that neostigmine can cause like heart rate, like or angina. But basically, they can definitely just collapse with neostigmine. So I would not use that. Another reason to use Sux. Sux is actually okay to use. Okay. Propofol is fine to use carefully. Remember, it vasodilates. So just be careful. Use it slowly. Okay. Ketamine can increase SVR a little bit, so just be careful, but you're not going to get the usual ketamine cardiac stimulation because the heart is denervated. Okay. So you can use ketamine, but just be careful because it can mix, like cyclosporine can have some neuro effects to it. So just be careful with that. Okay. NSAIDs are a no-go just due to the bleeding risk. You can give Tylenol though, so no Toradol. Tylenol's fine. Opioids, fine. Just be careful if there's any renal dysfunction, and be careful with the ones that are renally excreted and building up. So I would just probably stick with a little bit of fentanyl. Okay. And then titrating that as you need to, using some Tylenol. Bupivacaine, ropivacaine is fine if you want to do those type of nerve blocks. Beta blockers, they actually say to avoid those if the patient's hypertensive, because remember, these patients have circulating catecholamines that they are dependent on, right? They don't have the innervation of the heart anymore. So they need those circulating catecholamines to increase their SVR if they need it. Okay. So you don't want to block those with beta blockers. Okay. They say no nitrous because of potential bone marrow suppression from those, the cyclosporine, the tacrolimus is part of that. So, and I feel like nitrous is like, you can go back and forth with that all day, but that's what the literature has been saying. Atropine is not going to work because the heart is denervated. So it's not going to be able to utilize the anticholinergic effects of the atropine, right? Because there's no parasympathetic innervation as well, but you can use direct acting drugs. So essentially dobutamine is great, epinephrine, Levophed. And if you have bradycardia, use isopro. Okay. So use isopro for bradycardia, but remember, it may drop the blood pressure as well. Okay. All right. So I hope that empowers you guys that if you're on call and crazy thing happens, or maybe you work at a place where you routinely get heart transplant patients, this is kind of a review for you, but now you have this, you can add to your toolbox and you can go out there and provide some bomb anesthesia. Have a great day.